Good afternoon. Welcome to ASTCT's webinar on telehealth. I'm Alycia Maloney and I'm the Director of Government Relations for ASTCT. Today, we'll be talking about all of the regulations and CMS changes that have come out specifically for BMT and cellular therapy in response to COVID. This is a ever-changing space, so we expect to hear a lot more coming out of CMS in the next few weeks as well. So today's broadcast will actually be recorded, and this will be on ASTCT's website under our COVID community page. And so please feel free to share this with your colleagues and anyone else that might need this as a resource. So today, our presenters will be Valerie, Rinkle, and Jugna Shah from Nimitt Consulting. They are ASTCT's policy advisors, and they will help us walk through what's happening right now in this space. So I'm going to kick it over to Jugna to let y'all know the agenda and how this is going to go today.
Great, thanks so much, Alycia, and thanks to ASTCT for getting this together with us so quickly so we could bring it to you. We have to have the disclaimer slide that's in here. For those of you that have been, following this, you're probably feeling the way that we are, which is that information is coming at us fast and furious. And I feel like there's almost this sort of open office hours call from CMS, either every day or every other day and twice a day, and transcripts are being released for some of the calls. And I think what's pretty clear is that the agency is trying very, very hard to address, getting healthcare services out to patients and doing it in a manner that's safe to obviously physicians, healthcare professionals, and to patients. And so a lot of what's been changing rapidly in this space of both telehealth, but Valerie will talk to us about even beyond telehealth and how terminology matters. And so she's going to step us through a number of things and to try to ground us a little bit before she takes us forward in and what's changed now. And we just really caution everybody to take what we have today with today's kind of date stamp on it, and we will do our best to tell you where things are still evolving or where it's changing or where we're uncertain. We'll be very upfront about that. And so you'll just know to watch for changes in those areas. So you can see our agenda today. It's pretty robust. I think what's going to be really fun, if I can say that, is when we get a little bit to the clinical scenarios and then also some practical brass tacks in terms of operational considerations. So with that, I will turn it over to Valerie, who has been monitoring this very closely over the past couple of weeks.
Thank you, Jugna, and yes, thank you to ASTCT, and we're hoping this information provides you with what you need to continue to deliver services to your patients. So in this instance, terminology is really, really important because CMS has to work within existing rules and regulations, even when they have certain delegated authority that came out of the public health emergency, which was announced, and yet evolving under additional authorities which were granted under the COVID Act, the CARES Act, which we'll briefly talk about. So understanding what's possible given CMS's authority and what is not possible because it's constrained by statute is important. The good news is that CMS has made numerous changes over the past few years to what they call modernizing Medicare to better enable physicians and other clinicians and healthcare professionals to provide various services, which they enable or term virtual services or technology-enabled services, or perhaps under a broader umbrella of telemedicine, but they are different from telehealth services. At a high level, CMS considers each of these different services to be virtual or technology enabled, but there are specific distinctions that apply, and those distinctions translate into how you have coverage, how you code, and then bill the services. So the term telehealth is specifically defined by the statute and the Social Security Act. CMS in the last few years, though, has recognized virtual check-ins, which will distinguish what that is, recognized e-visits, and then as part of the public health emergency with the interim final rule with comment period, they have now recognized telephone visits. So telehealth services per the Social Security Act have a specific requirement. It's the use of telecommunication technologies that is real-time audio-visual. It supports what otherwise would typically be a face-to-face clinician-patient service. And it involves the patient being at an originating site and the clinician being an elsewhere distant site, okay? The beneficiary and the patient is at the originating site and the physician or practitioner is at a distant site. And note that this different location is still a requirement of telehealth through this public health emergency, although the Medicare has broadened dramatically where the patient may be as an originating site, including their home, and where the physician and practitioner can be in a distant site, including in their home. The technology, though, still must be this interactive audiovisual telecommunication system for real-time communication between the practitioner and distant site. The only exception to that is in Alaska and Hawaii that can use store and forward under a demonstration, which has a specific modifier, but that's not likely to be the circumstances that you're in. And then all telehealth services, both the originating site code and then the telehealth services rendered by the physicians and practitioners billed as telehealth, they are professional services payable under the Medicare Part B program. So prior to the public health emergency, there were very specific limitations on telehealth. The beneficiary originating site had to be in a rural health professional shortage area or outside a metropolitan statistical area and in certain facilities only. It was enabled outside of rural areas, so in all geographic locations for stroke and for opiate treatment programs, and then also for ESRD patients having home dialysis. So that was broadening in those three categories, not having the rural restriction. It had to be a service that was on the list of approved telehealth services that was services in lieu of an in-person visit. Okay, I apologize for the technical difficulties, everyone. So what I was explaining on this slide is that prior to the public health emergency, there were restrictions on the use of telehealth. Patients had to be in specific originating sites that were in rural areas defined as health professional shortage areas or those rural areas outside of a metropolitan statistical area. Then Congress expanded the originating site to enable a patient in any facility having suffered from a stroke, so urban or rural hospitals and whatnot, if they suffered from a stroke, they could have telehealth services. And there was a modifier added specific to stroke, or for patients that were ESRD patients receiving home dialysis and for opiate treatment programs. So Congress expanded telehealth in those circumstances beyond the rural restriction, as I like to call it. And again, prior to the public health emergency, other than those scenarios, that's the only time and circumstances with which telehealth services could be rendered, and it was from a more restrictive list of telehealth services. Since the public health emergency, CMS has expanded this now, and there are announcements on the web and there are announcements in the interim final rule, which is CMS 1744 IFC, and that's interim final rule with comment. That's where the IFC comes from, was all drafted and written prior to the Coronavirus Aid, Relief, and Economic Securities Act, or the CARES Act. So CMS has said repeatedly on numerous calls that they are reviewing all of the expanded and authority and flexibility given through the CARES Act and will be pronouncing additional changes in the near future. But right now, this is what they have announced. They've held calls on March 31st after March 30th when the interim filing rule was released. They had calls yesterday and they're continuing to have calls to answer questions. And it's pretty clear that their thinking is evolving. Therefore, it's vital to continue to monitor CMS announcements as more changes are going to be forthcoming. So the interim final rule, we've given you the link here. It's important to note that All prior web page announcements were effective as of the dates they were announced, but in this rule, they are making the changes retro to March 1st. There is a 60-day comment period, and CMS policies in this rule are beyond telehealth and other technology-enabled services. They affect physician supervision of home health, and numerous other benefits like home infusion therapy. So I don't want you to believe this rule is exclusive to telehealth or technology-enabled services. It is beyond that, but we're focused in this webinar on those technology-enabled services. So the major change that CMS announced through the interim final rule is they have dramatically expanded the list of services that are capable of being delivered by telehealth. They've added approximately 80 codes, and we've given you the link here, and the list is very good. It tells you the codes that existed on the list prior to the public health emergency, and then it notes those services that have been added due to the public health emergency. Added to the list are numerous types of codes like emergency department visits, all sorts of inpatient hospital visit codes, and group psychotherapy and ESRD codes, radiation treatment management codes. So most of the codes, I would imagine, other than very specific procedures, those codes that you could perform from a distant location for your patient population. Now, one of the things CMS did not make modifications on are to the types of practitioners that are eligible to bill telehealth, and we'll discuss that. But they did expand other clinician and practitioner types that can furnish and bill these other virtual or technology-enabled services. So those distant site practitioners that are enabled to bill telehealth, and there's a particular way we'll get into about how you bill for telehealth. It's physicians, nurse practitioners and physician assistants, nurse midwives, clinical nurse specialists, certified registered nurse anesthetists, clinical psychologists, and licensed clinical social workers, and registered dietitians or nutrition professionals. Now, of course, for LCSW and clinical psychologists, et cetera, it's only for the benefits that they've always been recognized under the Medicare program. It doesn't mean that they can treat patients of any diagnosis. It's still limited to those benefits. But in this instance, these are all Part B services. So they're billed on a professional 1500 claim. Each one of these practitioners has to have an active national provider identification number. If you have an employee in hospital or an entity that employs you, and so you're seeing their patients doing this like a hospital, if you're employed by a hospital, you must have been enrolled in Medicare and having reassigned your benefits to your employing entity. But then these services, because they're individual patient services, are still billed on Part B claims. From a technology, for the real-time audio and visual, they've updated numerous types of additional technologies that traditionally were not recognized during the public health emergency. Apple FaceTime is allowed, Facebook Messenger video chat is allowed, Skype is allowed, but there are still a few communication services that are not acceptable because they have some privacy and security concerns around them, and that is TikTok and Facebook Live. Furthermore, for telehealth services specifically, CMS is waiving the emergency condition code that's used on institutional claims and the emergency modifier CR used on professional claims and outpatient services. So you do not have to add the modifier CR when you're billing for telehealth in this circumstance. So let's go through when the patient is at an originating site. Healthcare facilities specifically are only eligible to bill for an originating site fee when the patient is actually physically present at their physical locations that are enrolled locations on their 855 enrollment form. So inpatient hospital, outpatient hospital, off-campus and on-campus provider-based departments, skilled nursing facility, other types of facilities, right? So when the patient is literally in the facility, then the originating site fee is reported with HCPC code Q3014. Now, of course, HCPC codes are billable on outpatient claims, so that code would print on an outpatient regular hospital claim, a critical access hospital claim, or for patients that have Part B only, a Part B only inpatient claim. You can still charge a charge for this on an inpatient claim if the patient's an inpatient, because the hospital's nurses and hospital equipment is facilitating that physician's telehealth, and the physician is a distant, different location. But of course, that charge is not going to generate any additional payment. Furthermore, when you have hospital employed practitioners that have not been billing professional claims up to this point, but who are using hospital equipment, registering and using the hospital's electronic medical record to document services that they're rendering to patients as telehealth services, there is currently no billing for them. The only billing, because it's truly a Part B service, is that, again, if they get an NPI, enroll, and reassign the benefit to the hospital, and there's $1,500 billing if they do that. CMS has acknowledged there's numerous questions and issues around this. They say they're working on additional rules that are subject to the CARES Act authority, but those have not yet been released. Now, as far as the interim final rule, they have changed what has been traditionally the billing for telehealth services up to the period prior to the public health emergency. So in acknowledgement the fact that physician practices are just transferring a huge portion of their professional practices out of their offices or out of the hospitals into patients being in their home and not physically coming into these locations, CMS is modifying and changing the billing policies effective March 1st. What they want the clinician to do is to use the place of service code that indicates where the service would have taken place if it had been delivered in person. And then from a payment perspective, the usual Medicare physician fee schedule facility and non-facility adjusters will apply. So for example, if the patient would have come into the outpatient hospital clinic for a BMT visit, then even if the clinician is in their home rendering telehealth to that patient, they would be billing an outpatient hospital, whether on campus or off campus, place of service code, okay? However, if the physician would have typically been seeing it in a medical office building that represents their outpatient practice, then the place of service code would be 11 for office. So you would use, if it's an inpatient, you would use the inpatient place of service code. Modifier 95 then is to be affixed to any of the codes on that list of telehealth codes that are rendered using telehealth, where the physician is in a distant location separate from the location of where the patient is. If a practice wants to continue using the prior place of service code representing telehealth, that will continue to be accepted. When that code is used, the facility adjuster applies. So what they wanted to do is pay the practice at the full non-facility or office physician fee schedule rate when the service typically would have taken place in the office, but it's taking place via telehealth. Now, when a non-physician practitioner is billing these telehealth services, the typical physician fee schedule adjustment of 15%, bringing the physician fee schedule payment to 85% will apply. So that is telehealth. Okay, so what about all these other, what they're calling virtual services, e-visits? What about telephone? These can be under the umbrella, considered to be under the umbrella of communication technology-based services and then telephone services. So virtual visits, CMS recognized them last year. Their codes are G2010 and G2012. These are covered in all areas, urban, rural, not just rural areas, so very different than telehealth. It includes the patients being in the home. And during the public health emergency, these are now being enabled for both new and established patients. Previously, it would have just been established patients, but now it can be used for new and established patients. They will furthermore allow distance site practitioners that are beyond telehealth practitioners, such as licensed clinical social workers, clinical psychologists, PT, OT, and speech pathologists, to perform these virtual visits instead of in-person services. But again, these are patients in their home. Clinician is wherever the clinician is using this check-in service. What's important to note is that these services are bound by the fact that a different visit, including what is a telehealth visit, does not occur within 7 days of the virtual service, or the outcome of the virtual service doesn't lead the clinician to say, you need to go to the hospital and I'll see you there, or you need to go someplace, or I'm going to convert and do a more in-depth E&M service with you via telehealth. Though it's bound by that. You do need to get a consent. You can have ancillary staff document a consent for all of these services one time, or if this is the first time you're doing it with a new patient, you can document it at that service and then make it broader for any subsequent services that occur. E-visits. E-visits are using a portal, and that doesn't mean that there isn't video. The video can be through the portal as well, but it's for online assessment and management of services. And again, this is in all locations, not just rural, and it includes the patient's home. So in addition to distance site practitioners for telehealth, CMS has clarified that other clinician types who may not independently bill for E&M services can also provide these e-visits as professional services and within the benefit categories, and they can be performed on new and established patients during the public health emergency. So for physicians and non-physician practitioners that can do E&M, it is the CPT codes 99421 through 99423. For other healthcare professionals, it is the G2061 through G2063, and you can see these are time-based services. Now, for the public health emergency and announced in the interim final rule, CMS is acknowledging and paying for telephone services because they acknowledge that not all patients, particularly those in their home, may not have access to real-time audio and visual. They just may have access to audio only through a telephone. So these had previously not been recognized but are now being recognized, and they will make separate payment for them. They can be provided to both new and established patients. And the 98966 through 98968 are these services when performed by clinician types that are not enabled to bill for evaluation and management services in their scope. And they can be performed by licensed clinical social workers, clinical psychologists, PT, OT, speech, when the visit pertains to a service that falls in the benefit category. In the interim final rule, and since many of the transplant centers are academic medical centers and training places, it's important to know how they have evolved supervision by use of technology. So you may acknowledge and know that many services under the physician fee schedule have to be performed under a specific level of physician or non-physician practitioner supervision, which typically necessitates the presence of the physician or non-physician practitioner actually in the physical location with the other clinical staff and the patient when the service is provided. But during the public health emergency, CMS is allowing the use of real-time audio and visual telecommunications technology for supervision. So this will allow the billing practitioner to observe the patient while interacting with or responding to the in-person clinical staff through virtual means. The clinician's availability to furnish assistance and direction can be met without the actual physical presence. And it does not mean that you have to hang on 100% of the time. In the rule, it's clear that it's as needed. Furthermore, there's certain services that for outpatient hospital patients, there was a requirement of direct, immediate availability of a qualified physician. And those specifically were cardiac, intensive cardiac, and pulmonary rehab. They are enabling that to occur via telehealth in the public health emergency as well. For teaching and faculty physicians, the supervision of residents performing E&M and other non-procedural services such as imaging tests and things like that can be provided either, of course, today as it is with physical presence, or use interactive telecommunications technology during the key portion of the service, which is where the supervision has to be. That can be performed via this telecommunications technology now. For residents in primary care programs, note that remember the residents could only bill the first 3 levels without the supervision, but the upper levels require the supervision. Now CMS is going to allow all levels of office, outpatient, E&M to be provided in the primary care services under the supervision by interactive telecommunication. And there is, though, the still requirement that if it is a surgical, high-risk, interventional, or other complex procedure, including those performed through an endoscope and those requiring anesthesia, in those services, they do want the personal supervision of the faculty physician. For residents, Medicare can make payment under the physician fee schedule for teaching physician services when the resident is furnishing these services themselves by telehealth while they're in quarantine. So the supervision of the faculty physician would be by interactive telecommunication technology. So many times quarantine, the residents are somewhat well, although hopefully with the availability of faster testing now, that quarantine time won't be quite so long. But if that were needed, then this could be, they could continue to deliver telehealth while having the supervision of the faculty physician by telehealth. Furthermore, they're expanding what residents can directly bill for and get paid for under the physician fee schedule in terms of moonlighting, if you will. They can bill directly and perform services that are not related to whatever the approved program is. So let's say they're in a dermatology program and yet they're helping out with your BMT patients, if you will, right? That would not be under their program. The services are performed in an inpatient setting of a hospital in which they have training. So if they're intubating patients on the inpatient side, needing to get them help getting set up on a ventilator or something like that, they can now directly bill and be paid for that under the physician fee schedule. Currently, moonlighting is allowed outside their approved programs in outpatient settings only. They're expanding it to inpatient settings. Of course, the services themselves have to meet all other conditions of being medically necessary and other conditions of payment. The resident has to, of course, be fully licensed to practice medicine, osteopathy, dentistry, or podiatry by the state where the services are performed. And again, the services cannot be performed as part of their or counted towards their training program. All right, we are going to get into a few clinical scenarios now, and we've chosen a few. And as we step through these may not be addressing those top of mind questions or clinical scenarios that you have concerns about. So we really invite you to ask questions through the question feature on the platform with clinical scenarios if these do not address your top of mind concerns. So our first scenario is the physician is at home and the patient is in the infusion department of the hospital receiving, for example, cell mobilization therapy. So the hospital is going to bill its normal outpatient hospital claim. And if they are facilitating telehealth with the physician in the home, then they can also add that Q3014 because the patient's physically in the outpatient department. And then there would be an outpatient visit code because the physician service is really a true E&M service, right? It's separately identifiable from the drug administration services for cell mobilization. So you would have Modifier 25. For physician billing, they would bill the appropriate level of an outpatient E&M for examining the patient. The physician is providing supervision as needed for this service using audiovisual technology. The place of service code we're suggesting would be on campus outpatient department because we're saying the department of the hospital is on campus. And then for that E&M code, the physician would put Modifier 95, indicating that it was performed via telehealth.
So Valerie, this is Jugna. I just want to ask one question on that. So the scenario, this is where you were talking about, even though the physician is at home, right, their place of service that they're reporting is 22 because that's where they would have normally been seeing the patient.
That's right. That's right.
Okay.
You report the place of service where you would normally have rendered the service with the patient if you had been in person, but instead you're doing it via telehealth. Scenario 2 is the physician and the patient are each at home, but the patient had originally been scheduled to come into the outpatient hospital department. So note that the patient is not present at the hospital in this scenario. So no UB billing for the hospital. Even though there may be use of the hospital EMR, electronic medical record, there's no billable service, excuse me. On the physician billing, the 1500 claim form, again, the physician would select the appropriate outpatient E&M service for the examination of the patient. The physician bills a place of service code 19 because we're saying the department they would normally have come to is an off-campus outpatient hospital department. That's where they would typically be scheduled to go. And so that's what the place of service code the physician would use. And then modifier 95 would be used. Now I want to pause here and say that while typically, of course, the physician is laying hands and doing a physical examination when they're rendering an outpatient E&M service, this is where CMS in the interim final rule and elsewhere has said that you can use time as the basis of selecting the code level. So that is something that they are enabling immediately, using your time as the basis of selecting the visit level. Scenario 3, the physician is at home and the patient's an inpatient. So the hospital billing is that the hospital would bill its typical inpatient claim, type of bill 111, for its usual all hospital services the patient's receiving. And then if they are enabling telehealth with maybe the nurse in the room and setting up the equipment with the physician being elsewhere, they can certainly have the charge for the patient being at the originating site and receiving those telehealth services. And in the charge master, the charge might have the Q3014, but of course, HCPCS codes don't print on inpatient claims. And to date, there's no announcement of separate payment in acknowledgement of the hospital's additional expense to set up the telehealth. In the physician billing, on the 1500 claim form, they would select the appropriate inpatient E&M code for examination of the patient. Place of service code 21 for inpatient is what is used, and then modifier 95 would be reported on that code. Now, the last scenario is, what about if the physician and the patient are co-located at the same facility, but the physician is still distant in that same facility from the patient, such as in a hallway outside the room or another floor in the hospital? Okay, so we're making this patient an inpatient. So the hospital billing is the same billing of whatever inpatient services the patient's receiving, but this is not telehealth. So there's no originating site fee for the hospital in this situation, no telehealth. Now, what about the physician billing on the 1500 form? In the telehealth FAQs that are posted on the CMS website under the emergency, CMS specifically answers that the physician could bill, but this is not telehealth because the patient and the physician are co-located at the same facility, but they acknowledge that the service can be reported. Yesterday, in an answer to the open office hours call that CMS held later in the afternoon at 5 p.m. Eastern, they said in this scenario, the clinician would just bill the regular hospital E&M inpatient code. It just would not be reported as telehealth. However, we want to caution that this is not yet anywhere in written guidance, and it's not specifically stated in the interim final rule or even implied clearly in the interim final rule. So our concerns are the fact that we feel that CMS's answers to some of these questions have been evolving. So we ask you to stay tuned and watch for whatever CMS releases in writing. And in this instance, the physician would bill the place of service code 21, obviously, since the patient is an inpatient. So again, as I wrap up.
So Valerie, so let me ask you a question. So would this be the kind of example of something that folks should write in terms of the comment period for the interim final rule, right? To sort of acknowledge, CMS, you've said this, and then you've verbalized this particular answer. We'd like you to confirm that indeed you could use, the regular E&M codes. Like, is that the type of thing that you'd encourage people to submit in a comment?
Not just in the comment to the interfinal rule, but I'd encourage them to submit that to the open email address that CMS has set up for COVID-19 questions as well, because this is becoming fairly urgent, right? Since this goes retro to March 1, Many visits are accumulating, and facilities don't and physicians don't know how to bill it.
And so you guys, that's when I was saying a little bit earlier when we couldn't hear Valerie, and I was saying, get your comments in either, both through that regulations.gov, but also as Valerie's pointing out through I think it's COVID-19 at cms.hhs.gov. Getting them in through that route gives them an opportunity to read them, review them, and maybe they'll continue releasing guidance now. And then ideally it would all sort of get addressed in the final rule, right, that would come out after this comment period is over. But they definitely need to hear from clinicians and practitioners.
So just to point out some key operational considerations that you may be hearing. Now, this is more directed to your program managers and directors of your BMT programs, and there may be lots of conversations in facilities around some of these issues. So wherever your system, I'll use Epic as a good example, there's both professional billing and hospital billing on Epic. So if you have an EMR where the clinicians have access to the professional billing component and professional part of the EMR, then that's what should be used for billing all forms of telehealth, virtual services, e-visits, now these telephone visits. You would want to open up a record, document, of course, under the patient, document the place of service. I would suggest you document the specific type of technology, the location of the patient versus the location of the clinician. Particularly specify if it's both audio and visual versus audio only. Obviously, that would designate whether it's a telephone versus a telehealth or one of those other services. And then the place of service code is the location where the service would have otherwise taken place. And I've listed some examples here for you. When the patient is physically at the hospital or the facility as an inpatient or an outpatient, then the originating fee could be used. If it's an inpatient or outpatient, then typically the clinician is going to be using the hospital portion of the EMR for documenting the services. Now, what about hospital accounts? As this emergency and crisis continue to evolve day after day, clinicians were just responding to patients' needs as appropriate, of course, and doing so using whatever technology they had at their hands to protect both themselves and the patients. So when the hospital EMR was used for hospital employed and other privileged practitioners to document these services, so they quickly registered a hospital account, they activated the hospital account, they're using the electronic medical record to document the services that are occurring with a patient at a distant location. These activated accounts are now being discharged and accumulating in work queues. They're needed. You had to have an electronic medical record open up for the patient, for the data service, for the clinician to document actually what they rendered. But these accounts are likely queuing up in your patient accounting system. And there's a bunch of questions of what charges do we put on these hospital accounts? Can we code them? Can we bill them? Right now, with everything that CMS has published, if the patient was physically at your location, then there is something for you to bill. There's that site origination fee, as we said, if the patient was an outpatient. Obviously, if they're an inpatient, there's a lot the facility can bill. But for these distance services where your employed staff were rendering them and the patients were in their home, but they're using the hospital system, there is no hospital billing for that as of yet. But it is important to track what the services are for statistical tracking. It's going to be important when the cost report is filed to maybe have documentation related to the volume of these services. And so you're going to want to track that, but you're also going to want to eliminate these from having to go through coding and producing a claim, right? So if IT can do queries based on maybe the charge for statistical purposes, but then get it out of the coding work queue, getting it out so it doesn't produce a claim, so that there's not additional unnecessary staff time on those accounts. Now there is emergency enrollment. So hospital employed practitioners with E&M in their scope, as I mentioned earlier, such as physician assistants, nurse practitioners, clinical nurse specialists, Those can all obtain MPIs if they don't already have them. If they've never enrolled, they can enroll under the emergency enrollment and then reassign their benefits to the employing hospital if need be. Then the hospital submits the 1500s for them. Other hospital employed clinicians such as PT, OT, speech language pathologists, dietitians, and nutritionists for diabetes management, self-management training can obtain NPIs as well. They can also do emergency enrollment and reassign the benefit, and the hospital can submit pro fees on behalf of these services through that emergency enrollment and 1500 billing. Enforcement details. So the Office of Civil Rights will exercise discretion and will not impose penalty for non-compliance with HIPAA regulations during the public health emergency. And the HHS, OIG, and the Department of Justice are all intending to try to monitor to the best of their ability any potential fraud and abuse via the technologies or other scams that might be occurring during the crisis. And the OIG is going to allow providers to waive coinsurance deductibles for telehealth services. And just announced also is that if out of the visit, the clinician is ordering a COVID test, then that E&M visit where they decided, or telehealth visit where they decided to order the COVID test, that would get Modifier CS, and that waives the coinsurance on the E&M as well, and Medicare will pay the 100% in that instance. So this waiver applies to the hospital not obtaining it or the clinician not collecting the 20%, but the CS modifier under the Families First Act enables Medicare to pay 100% of the E&M instead of 80%, and the patient would not have copay. And then, as I mentioned, we have numerous URL links for you here, including the list of telehealth services again, the telehealth FAQs that we've referenced, what's occurring under the waiver, and a clinician letter that was just released yesterday as well. And so with that, I think we may have opportunity for any questions.
Great. And Valerie, I think we've got two questions that I'll get us started off with. And again, we'll encourage the audience. Thank you for your time today and your patience. We do have about 7 minutes left. And so we'd love to hear any other scenarios or questions that you might have. So Valerie, one question is back to kind of terminology. Can you explain a little bit about I guess the definition and the difference between hospital without walls and then the alternative care locations?
Yep. So actually those are interchangeable terminologies. So under the waiver, Medicare has enabled hospitals following the emergency pronouncements of their states to open up alternative care sites. These care sites would aggregate patients of a certain type. So it's not a home, a patient's home is not an alternative care site, but a convention center where they're setting up beds to treat inpatients, whether they have COVID or not, that is an alternative care site. And so that is also somewhat referred to as a hospital without walls. So under the provisions of the emergency waiver from CMS, the blanket waiver, and then in the restrictions of the particular state, then alternative care sites can be set up. It can be a hotel, it can be a convention center, and it can be for any types of patients that otherwise would need facility services and hospital services in this instance. And so that's what the alternative care sites would be. And so then the place of service code for telehealth would be, is that status of the patient inpatient in that alternative care site, or if not? In these instances, the claim would have the emergency modifier CR, and then the actual location on the 1500 claim would designate that alternative care site.
Great. So another question is, given the information that is coming out through the phone calls that CMS is hosting when they answer questions that people are asking, and then when that comes out in a transcript, are you supposed to follow that? Or are you supposed to follow, what's in an FAQ on their website? And can you
Yeah.
use what they're saying as sort of your rationale or documentation, if you were to be audited, although you said there's going to be a lot of leniency in terms of, the OIG and looking back at this stuff.
Right. I would say that if you have the actual audio taping of the calls, or the transcript is published and the answer is published in the transcript that you get from the CMS website, then I do believe you can start to rely upon that guidance given through the calls, as long as you have formal documentation what was said on the calls. But I want to caveat that it's possible that the answers on the calls I do believe they're still evolving. And so you need to watch for whatever guidance CMS might release, for more formal guidance CMS might release subsequent. And it's possible that that more formal guidance could change, and it possibly could mean you need to be prepared to go retroactively back and make adjustments if you've released claims based on the transcription of the calls and the answers that were given there. So I do believe at the end of the day, you're going to want some formal written proof of why you made the decisions that you made. And so you just want to be monitoring for that. That's how I would answer that.
And so Valerie, the flip side of that, and this is my question, we don't have any other questions in the queue, so I'll ask this one. You've mentioned this on the program today, and you and I have had some conversations about this, and the question keeps coming up to CMS about the hospital being able to bill because the hospital's resources are being used, but they're not able to bill today, when the patient is not there. And so what kind of documentation? So, so two-part question. One, do you think that's going to change, right? Is CMS, I mean, they seem to be wanting to work to resolve that. And so if that were to change and hospitals were able to bill, what kind of documentation would you want them to have now so that they could go back and bill so that the hospital can get paid?
So if I were had a crystal ball, I think what CMS will be changing in the future is, for example, PT, OT, and speech, right? Enabling the hospital that employs those therapists to put the pro fee services on a UB claim, just like they do put the therapy services on the claim today, designate them as being virtual or via telehealth, and continue to pay those outpatient services under the physician fee schedule, just like they do today when the patient's physically in the outpatient therapy department. But what I don't think CMS is going to enable, or it would be very challenging for them to enable it, is if the nurse practitioner is employed by the hospital and the nurse practitioner is rendering a telehealth service, the nurse practitioner previous to the emergency never billed a 1,500. I don't think CMS can allow that to be on a UB, because that really is a patient-specific Part B service that needs to be paid under the physician fee schedule. So if I had a crystal ball, I'm thinking that CMS will be able to modify hospital billing to some extent, but not 100%. And so that's why we have the information in here that you really do need to make sure those practitioner types that are enabled to perform full telehealth, that they get their MPI, they emergency enroll, and they reassign their benefits, and that 1,500 claims, because those are patient-specific services. That's what it means.
Great. And Valerie, in our scenarios that we did, when we think about BMT, and again, this is why your guys' scenarios are really helpful, because you're much closer to all the different ways in which services are rendered and where in the course of treating the patient, right? Different things are happening for the patient. But I'm trying to think about if you've got patients that were sort of in the queue, right? They're gearing up, they're going to be getting a transplant, for example, but they're nowhere near the hospital these days, right? And so the clinicians are managing them from afar. So either from the hospital or from their home. Those are some of those scenarios that you stepped us through that people would want to take a look at. Is that right?
That's right. That's right.
Okay, great.
Where would the patient have typically been if they had been able to receive the service that they were typically scheduled to receive, other than the patient being in the home, for example? Correct.
Okay, great. Thanks so much. All right, well, Alycia and Kira, I'll turn things back over to you just as we're approaching the top of the hour.
Thank you both so much for that. So like I just wanted to reiterate that this has been recorded and will be posted to ASTCT's COVID community page. And we apologize for the technical difficulties and appreciate you sticking with us through this. So please feel free to reach out if you have any questions following this to either myself or Jugna or Valerie, and we're happy to get back to you. Thanks so much for listening in.